We have some questions by the connected people. We cannot see, but they are connected. So there is a question: what are the lymphoria outcomes when using ADM? And this is a question for people using ADM. There was here on the podium. Where is it? Okay. Catellani, Leonardo, if you want just to give an answer, quick answer, so we can satisfy more questions for everyone. Yes. What are the lymphoria? I mean, obviously, the fluid and seroma that you can have when using ADM in this patient.
Radiotreated patients?
Yes.
Okay. There are 3%, 4% of late lymphoma accumulation. I don't know if it is the same thing that lymphoria. Lymphoria is a term I don't use, but anyway, late seroma 3-4% in radiotreated patients. Okay, so it's a little bit more compared to the non-radiotreated patients. Of course. Okay, thank you. As expected. I have a question for Paetke. Stefan, in your data, maybe I'm mistaken myself, but you showed that in 80% of patients you don't have any problem related with capsule contraction after radiotherapy. Is it true?
Yes.
And do you use just a total coverage, I mean the pocket, or just a dual plane approach?
What we did in the past, so that is nearly the same time as Roy changed from subpectoral to prepectoral, reflecting the subpectoral, the problems were bigger. Switching to prepectoral, what we have seen is the postoperative complications are much more lower, significantly lower, and also the problems with radiotherapy. So I would say the basic level of problems with radiotherapy regarding capsular contraction is between 8 and 10%, and with radiotherapy we have relatively 50% more. So I have patients with a really early capsular contracture, Baker 3, and that is independent on pre-pack or sub-pack. But with the switch to prepectoral implant positioning, the problems are decreasing.
Fine.
And the cosmetic result and the patient reported outcome is at the same level. As Andrea was showing also, we have a general good level of patient reported outcome, around about 86 to 92%.
Okay, so the majority are prepectoral in any way. Your data are related to prepectoral. I have one question to Icro.
Me too.
Okay, sorry.
No, it's okay.
Icro, do you think that the new technology, compared to the paper published that you quoted in your speech, with the new technology in a few years, we can have a different scenario related to implant and radiotherapy?
I think that the new techniques already allow us to improve our outcomes, basically, and contouring guidelines already exist, and it's strike a balance, basically. The prepectoral, obviously, for us, still not allowed to reduce the radiated volume that could be absolutely done when you are post-pectoral, obviously, because it's really better for us in guideline and contouring. But on the other hand, the prepectoral, has the other speakers outstandingly said, reduce these unfortunate worse outcomes. So also in my routine practice in our breast unit, we usually use a prepectoral approach a lot, and we have no specific concerns in irradiated patients. So this is a balance between technique, selection of patients, and your new surgical approach.
Igor, just one question. What's your cutoff for decided to do or not radiotherapy? How many nodes? Because
Nodes.
yes, it means that three
we have
nodes.
not time.
Yes.
How many days you have got to discuss this?
Because 3 nodes were usually the
that's a
cutoff.
problem. Yeah, that's a hot burn question. Since if you stop doing lymphadenectomy, then I will be not any way aware of the number of nodes, positive nodes. In my opinion, the most of patients that should receive post-mastectomy radiation therapy, the cutoff is 4.
Okay.
4 and more. But nowadays, a lot of patients with 1 to 3 positive nodes should receive post-mastectomy radiation therapy based on biology.
Yeah.
So that's the burning question. I still trust in 4 nodes, but there's increasing number of patients receiving post-mastectomy radiation therapy also between 1 to 3. And what if I am not aware of the number of nodes in the future? So that's another Congress probably.
Thanks a lot.
Definitely.
Yeah.
Short question. Also, the tumor size, more than 3 centimeters, maybe there is an indication for radiotherapy, no, Icro?
No, not necessarily.
No? Okay. So another question is for Andrea. Andrea, are you with us? You are not following the discussion? Okay, so there is another one for you,
Yeah.
Roy. Is there increased rate of ALCL seen with polyurethane implants?
Now, I think it's very important to come to the meetings because you can enlarge your knowledge. But this question is a very well-known answer. Polyurethane doesn't have an increasing rate of ALCL. A lot of the few cases that we have are all related to the Silymed, the difference between Silymed that is not anymore on the market with that kind of implants, and Polytech, that is the only one on the market with polyurethane, is the way in which is vulcanized the polyurethane foam around the implant. Then we have just 2 cases until now in the world. I don't think, in my opinion, probably a lot of you knows perfectly my position on ALCL. I think it's a very important issue. But actually, we are monitoring the situation since many years, and what we believe that were underestimated now is not underestimated anymore, and the numbers are stable along the years. With different, in Italy, we have 1 out 25,000 cases. But I think it's very important to know what we are facing, the problem that we have to check. We have very tight follow-up. That is, now we are talking about breast oncological patients. Then it's not a great problem because the oncological patient do every year a follow-up for the disease. And then actually it's not so difficult. The problem could be more important for the aesthetic one because not only surgeons that do the aesthetic surgery do a very tight follow-up or very accurate. That's the problem.
Anyway, if you just give a look to the sheer conclusion, you can have the answer. So really, until now, there is not a real association between surfaces and the LCL. So that's the final conclusion of the shear. The shear more or less is FDA in Europe. That's these are the
final
conclusion.
statement.
Okay, fine. So we are on time. We can go ahead. I ask, thank you so much to Stefan. Thank you so much to Icro.
Thank you.
To Andrea, to the other speaker. Pleasure to have you always. And
Our pleasure.